Welcome to This Week in Pediatrics. This week we are covering 10 notable papers spanning critical advancements in neonatal and perinatal care, cardiovascular and intensive care monitoring, and strategies for improving equity and long-term screening in primary care. Let's dive in. We begin in the neonatal intensive care unit, where 3 recent publications highlight the delicate balance of optimizing therapies while minimizing procedural harm. First, a systematic review and meta-analysis. Analyzing 26 randomized controlled trials that included nearly 3,900 neonates, the investigators found no significant differences between the two modalities in the rate of bilirubin decline, follow-up, bilirubin levels, hospital length of stay, or mortality. Interestingly, intermittent phototherapy actually reduced the overall duration of phototherapy by an average of roughly 10 hours. While the certainty of this evidence remains low to very low, these findings suggest that intermittent phototherapy is a highly reasonable, time-efficient alternative that may support better parent-infant bonding and ease nursing workloads without compromising clinical efficacy. Moving from non-invasive therapies to highly invasive procedures, another systematic review in the European Journal of Pediatrics addressed the challenging issue of pain management during laser photocoagulation for retinopathy of prematurity. While general anesthesia is the recognized standard of care, many resource-limited settings rely on local anesthesia or sedation analgesia. Examining 4 small randomized trials involving 265 infants, the authors found that non-general anesthetic regimens, ranging from oral dextrose and sucrose to fentanyl and ketamine propofol, consistently failed to provide adequate pain control, leaving most infants in moderate to severe pain. Furthermore, safety concerns were prominent, with apnea occurring as the most common adverse event, particularly in up to 30% of infants receiving high-dose fentanyl. The clinical takeaway here is clear. Whenever possible, general anesthesia should remain the standard for this highly painful procedure, and current alternative sedation protocols require extreme caution and close respiratory monitoring. The theme of neonatal respiratory vulnerability is further explored in a post-hoc analysis of the BET-ADOSE trial also, which investigated whether we can safely reduce the dose of antenatal corticosteroids. The study compared a half dose of betamethasone to the standard full-dose regimen in very preterm neonates born before 32 weeks of gestation. While there were no significant overall differences in surfactant use or bronchopulmonary dysplasia, neonates in the half-dose group were more likely to be discharged home on oxygen. More concerningly, in a subgroup of infants with intrauterine growth restriction, reducing the dose led to a higher rate of surfactant use, 63% compared to 42%, and a higher rate of bronchopulmonary dysplasia, which rose from 24% in the full-dose group to 40% in the half-dose group. Although these subgroup differences did not remain statistically significant after correcting for multiple comparisons, they represent a strong warning signal. Clinicians should be extremely hesitant to reduce antenatal corticosteroid doses, especially in pregnancies complicated by intrauterine growth restriction, where full-dose betamethasone remains critical for lung maturation. Next, we turn to pediatric cardiology and intensive care, where precise physiological monitoring is paramount. A retrospective study of 200 consecutive children undergoing congenital heart surgery with cardiopulmonary bypass evaluated the clinical impact of postoperative fluid accumulation. The researchers defined a clinically relevant positive cumulative fluid balance as a 5% or greater increase in body weight by the end of the first postoperative day. This threshold was met by 36% of the cohort, with lower body weight and longer cardiopulmonary bypass times emerging as the primary risk factors. Crucially, even this seemingly minor 5% fluid overload was strongly associated with adverse outcomes, including a higher incidence of acute kidney injury, higher vasoactive requirements, and prolonged mechanical ventilation. In fact, every single % increase in cumulative fluid balance on day 1 lengthened the pediatric intensive care unit stay by nearly a day. Furthermore, patients with a positive fluid balance had lower cardiac event-free survival during long-term follow-up, suggesting that early fluid overload is not just a transient postoperative issue, but an early marker of a complicated long-term clinical trajectory that warrants aggressive fluid management and structured follow-up. In the outpatient cardiology setting, diagnosing left ventricular hypertrophy in children with primary hypertension has historically been hindered by the poor diagnostic accuracy of standard electrocardiograms compared to echocardiography. To address this, a retrospective study of over 500 hypertensive children, pediatric-specific electrocardiographic nomogram, Because chest wall fat in obese children attenuates electrical voltage, the researchers innovatively integrated body mass index as a corrective factor alongside two composite electrocardiographic indices. This newly developed nomogram demonstrated excellent diagnostic accuracy, achieving an area under the curve of over 0.80 in the validation set. By compensating for body mass index-related voltage attenuation, this practical tool significantly improves our ability to detect left ventricular hypertrophy early during routine clinic visits, allowing for timely intervention before hypertensive target organ damage progresses. We now transition to long-term pediatric outcomes, beginning with a disturbing look at disparities in chronic respiratory care. A study. The researchers found that Black and Hispanic infants were significantly overrepresented in these clinics compared to their states' general preterm populations. Even after adjusting for baseline clinical factors like younger gestational age, lower birth weight, and longer initial hospitalizations, Black and Hispanic children experienced substantially worse outpatient outcomes. Black infants had a 54% higher likelihood, and Hispanic infants had a nearly double likelihood of requiring emergency department visits or hospital readmissions for respiratory issues compared to their non-Hispanic white peers. These findings highlight a critical need for pediatricians to look beyond clinical risk factors and actively address the social determinants of health and structural barriers to care that drive these profound disparities in chronic disease management. Predicting and preventing chronic disease trajectories is also a major focus in allergy and immunology. In the European Journal of Pediatrics, a prospective cohort study of nearly 447 infants with food allergies investigated the predictors of the atopic march, specifically, who will go on to develop allergic rhinitis by age 6. By applying machine learning models to longitudinal clinical data, the researchers identified 4 highly accessible predictive features: a parental history of allergic rhinitis, the frequency of childhood antibiotic use, the specific use of cephalosporins, and daily exposure to tobacco smoke. A validated logistic regression model incorporating these factors achieved high predictive accuracy. For practicing clinicians, this study provides a clear roadmap for early intervention. While parental history is non-modifiable, we can actively counsel families of infants with food allergies on the importance of strict tobacco, smoke avoidance, and the critical role of antibiotic stewardship in early childhood to potentially disrupt the progression of the allergic cascade. Early identification is equally vital in behavioral pediatrics. A longitudinal study, or ESSENCEQ, for neurodevelopmental screening during routine 18 and 36-month health checkups in Japan. Looking at over 1,300 children, the study compared questionnaires completed independently by mothers, public health nurses, and psychologists. While the overall prevalence of neurodevelopmental disorders was 11%, the study revealed that questionnaires completed by mothers alone were not sufficient for standalone screening. However, when completed or supplemented by public health nurses or psychologists, the tool showed excellent diagnostic performance and reproducibility, particularly at the 36-month visit. This underscores that while parental concerns are an invaluable starting point, optimal developmental screening requires a collaborative approach where standardized tools are interpreted and supported by trained professionals. Our final thematic area focuses on primary care delivery, communication, and safety. Effective communication is the cornerstone of pediatric medicine, yet a cross-sectional study in pediatrics reveals major gaps in how we care for families who prefer languages other than English. Interviewing over 100 caregivers across pediatric clinics in the United States, the researchers found that while 85% of families received professional interpreter services during their direct interaction with the physician, support plummeted during other critical touchpoints. Only 56% had language concordant services during scheduling, 39% during rooming, and less than 1/4 received translated written materials like pre-appointment reminders or developmental questionnaires. This study is a call to action for clinic administrators to implement systemic clinic-wide language services that cover the entire patient experience, from the initial phone call to the written discharge instructions. Finally, maintaining public trust in primary care interventions requires robust ongoing safety data. A comprehensive narrative review in Acta Pediatrica provided a reassuring safety update on acellular pertussis vaccines. Synthesizing decades of epidemiological data, the review confirmed that while mild local reactions like redness and transient fever are common, moderate reactions such as prolonged crying or extensive limb swelling are rare and self-limiting. Most importantly, Large-scale studies show no consistent increase in severe outcomes like seizures or encephalopathy above background rates. These findings provide clinicians with the strong, evidence-based reassurance needed to address vaccine hesitancy and confidently promote pertussis immunization programs. If you only have time for one paper this week, make it the pediatric-specific electrocardiographic nomogram for detecting left ventricular hypertrophy in hypertensive children. This study is a top pick because it directly solves a daily clinical dilemma, the notorious insensitivity of standard electrocardiograms in children, especially those with high body mass index. By integrating body mass index as a simple corrective factor for chest wall fat, this model provides an exceptionally practical, highly accurate and low-cost tool that any clinician can use to improve early target organ damage screening right in the office. Here are the key takeaways from this week in pediatrics. First, for neonatal jaundice, intermittent phototherapy is a highly effective, time-saving alternative to continuous therapy, reducing treatment duration by an average of roughly 10 hours with comparable bilirubin control. Second, non-general anesthetic sedation regimens for retinopathy of prematurity laser surgery are largely inadequate and carry a high risk of apnea. General anesthesia should remain the standard of care whenever available. Third, Black and Hispanic children with bronchopulmonary dysplasia face significantly higher rates of emergency department visits and hospital readmissions, requiring clinicians to actively address social and structural barriers to outpatient care. Fourth, fluid overload is a major driver of poor outcomes after pediatric cardiac surgery. Even a minor 5% positive cumulative fluid balance on day 1 is associated with acute kidney injury, longer ventilation, and worse long-term cardiac survival. Finally, when screening infants with food allergies, we can help prevent the progression to allergic rhinitis by emphasizing strict tobacco, smoke avoidance, and careful antibiotic stewardship. That's your roundup for this week in pediatrics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.